recording.
Okay. Cool. All right. So we're going to start off with heme malignancies today. I said it will be speedy, and that's because heme malignancies is honestly not the highest yield topic in SEM 2. Heme itself is only like a handful of marks on the exam, and then of those, probably half will be like anemia based. So there's not a whole lot to this, and if you do get examined on it, it'll likely be buzzwords. So just focus on that. So we'll start off with like the overview. So you'll be very familiar with this diagram by now, I'm sure. You'll have seen it many times. And it is very helpful when we look at malignancies as well, because you kind of look at where the malignancies can happen. So when we talk about a leukemia, it's a malignancy of the progenitor cells. So either your common myeloid progenitor or your common lymphoid progenitor. So you got myeloid and lymphoid, and then acute and chronic, and that gives you your 4 leukemias. The myeloproliferative neoplasms, also called myelodysplastic syndromes, is malignancy of the myeloid cells. So specifically looking at this branch, all of these cells under here. And then based on what kind of cells are proliferating, you get your different kinds of cancers. So you've got essential thrombocythemia, which is thrombocytes, so your platelets. If it's red blood cells, that's Polycythaemia rubra Vera. And then if it's sort of general leukocytes, that's CML, sorry, that should be CML. And then if it's everything, it's primary myelofibrosis. And then the lymphoids is this branch. And so that's going to be malignancies of your T cells or your B cells. And they can be classed into T cell versus B cell, but they're also classed into Hodgkin versus non-Hodgkin's lymphoma, which we'll talk about. It's basically like the presence of a type of cell. And then multiple myeloma is specifically malignancy of plasma cells. So this one down the bottom here. So we'll start off with our leukemias. So when it comes to leukemias, it's looking again at that common myeloid or lymphoid progenitor, and there's different categories. So if it's acute, that means you're going to have really large, poorly differentiated, non-functional blasts. So just these like really big, immature cells that are very non-functional. So it makes sense that that would be like more aggressive, more symptomatic. Your chronic ones, they're more like slow growing, and the cells themselves are more mature. So you've got smaller cells, they're more well differentiated, and they're not completely non-functional, but they are poorly functional. And then, so that's acute versus chronic, and then you've got lymphoid versus myeloid, and that's just talking about what cell type. So if a blood film shows like large, poorly differentiated T cells or B cells, then it will be some kind of acute lymphoid leukemia. Whereas if it's of like neutrophils, then it will be a myeloid leukemia. So they're just named based on like the cell type. And then just for sort of fun facts, the relative prevalence kind of goes in this order. So we'll talk about each of them individually, but CLL is very indolent and very common. People usually die with this leukemia, not of the leukemia. And then in terms of mortality, AML is the most aggressive. When we're diagnosing leukemias, it's based on 3 main things. So bone marrow biopsy, and that will show like loss of the normal marrow and then replacement with all of these like proliferating cells. So typically hypercellular. The blood smear and the FBE, so that's going to be looking at, you know, like the peripheral blood film and all the kinds of weird cells that you see there. And then immunophenotyping is done to look for specific genetic mutations, because a lot of these blood cancers are linked to very specific mutations. So starting with AML. So the demographic for this, it's usually older adults and often with a history of some kind of myelodysplastic syndrome. So maybe they had like Polycythemia rubra Vera in the past, and then it progresses to AML. In the peripheral blood film, this is what you're looking for. So blasts, anytime you hear blasts, you're thinking acute leukemia, because these are your massive immature cells. And then these OA rods, which are like tiny little rods that you can see here included within the cell. That's like a buzzword for AML. The bone marrow biopsy, like we said, hypercellular, lots of cells of the myeloid lineage, because you've just got massive proliferation of that progenitor cell. The key features. So the idea that you're thinking here is like these symptoms, first of all, because it's a cancer. So they're going to have fever, fatigue, weight loss, night sweats. That's pretty much common to like all of these blood cancers. And then because your normal bone marrow is being replaced by these cancerous cells, you're going to get loss of all the other kinds of cells that you should be getting from the bone marrow. So there'll be anemia, there'll be thrombocytopenia and neutropenia. And so then when you're thinking of clinical symptoms, you just think about what each of those would do. So neutropenia will give you infections. If someone has low platelets, then they're going to be more prone to bleeding and bruising. So you're looking for those kinds of things. And anemia, your classic symptoms are pallor, fatigue, shortness of breath, palpitations, dizziness, even syncope, but mainly dizziness. So that's sort of the categories of the clinical presentation. Another thing that's kind of buzzwordy for AML is that you get blasts depositing in peripheral areas. So there's other kind of random symptoms, and one of them is gum hypertrophy. So that's a bit buzzwordy. This is the most aggressive leukemia, so the prognosis is pretty bad. It's less than 2 years. Chronic myeloid leukemia, on the other hand, so again, still older adults. The buzzword for this one is Philadelphia chromosome. So they're associated with this particular translocation. Peripheral blood film shows left shift with normal lymphocytes. So left shift means they're a bit immature, but the lymphocytes themselves are normal, because remember, this is a myeloid cell leukemia. So if you compare this sort of peripheral blood film with the previous one, you can see that these look really sort of big. They're really immature, like the nucleus is massive, but you're not getting this kind of segmentation that you sort of expect to see. Whereas these are sort of, they're segmented, they've got that more like granular sort of appearance. They clearly look like more mature functional cells than these big boys over here. Bone marrow biopsy, moderate hypercellularity with left shift again. So slightly less bad than acute myeloid leukemia, but still a bit more on the immature side. And then the key features, so chronic myeloid leukemia has 3 phases. And the first phase can last sort of varying lengths of time. It's like asymptomatic phase. It's often an incidental finding on like a blood test. But if they do present with symptoms, it'd be sort of vague, mild B symptoms, and then splenomegaly as the other one. Then it can progress to an accelerated phase, and that's when you start getting symptoms because of the loss of the bone marrow function. So your anemia, thrombocytopenia, leukocytosis, same as AML. And basophilia is another one. So weirdly, not really sure why, but weirdly they get lots of basophils. So they might have pruritus, which is itching. And then the third stage, if it gets to it, is the blastic phase, which is basically AML. So it can essentially progress in like the speed of the proliferation, and it can get to like an AML type stage. So the prognosis varies, but this is actually essentially treatable now with a new, relatively new treatment, the tyrosine kinase inhibitor. So this is less bad than AML for sure. Then we've got ALL. This is the least common of the leukemias, but in children, it's probably the most common, the main one. So if you've got like, if the question stem is like a child, a young child with leukemia type symptoms, then it's most likely to be ALL. It can also happen in older adults though. So the peripheral blood film, again, you're looking at blasts because it's acute, but this time lymphocytes. So lymphocytes, it's kind of hard to like interpret blood films, and honestly, I don't think you'll be asked to in second year, but you can kind of see that lymphocytes are like very dense, kind of, they're slightly smaller than the other white cells. So these ones here, they're a little bit smaller, and they're very sort of dense and blue, like this, very dense and blue. So the bone marrow biopsy is again very hypercellular, and you'll see lots of blasts. And then the key features again are kind of similar. So the idea is, again, bone marrow is being lost because of invasion by these cells. And so you get all these symptoms of anemia, thrombocytopenia, and neutropenia. And then because the immune cells aren't being able to be produced at the bone marrow, you get extramedullary synthesis, and that would happen at the liver and the spleen. So you get hepatosplenomegaly. So this one, it can spread and spreads typically to areas of high vascularity. So the 3 Bs, brain, bones, and balls. I don't think you'd actually get asked much about that, but it was in the notes, so I threw it in. And then in terms of prognosis, because this is more common in children, it's actually quite good prognosis because they tolerate chemotherapy very well, but it's not too bad in adults either. And then the last of them is chronic lymphoid leukemia. So this is the one that is most common, very indolent, and not very deadly. So it's classically like very elderly people, but it might have been diagnosed like incidentally when they were younger. So on the blood film, you see small, mostly mature lymphocytes. It's pretty hard to differentiate them really, but the idea is that they will have lymphocytosis. So they will have lots of lymphocytes, and those lymphocytes will be slightly less mature than they should be. And then the other one that's kind of a buzzword is smear cells. So these cells that are sort of a bit fragile and they get damaged when you're doing the blood film. Bone marrow biopsy might be slightly hypercellular, but it's not usually a problem. And then the key features is actually lymphadenopathy. So this is one of those ones where it's like kind of contentious. It's called a leukemia, but it actually gives more like lymphoma type symptoms because you get lymphadenopathy with it. And then in later or aggressive disease, you get all the other sorts of signs as well. But the idea is just that genuinely that this like doesn't tend to present with major clinical symptoms. Very few have the B symptoms. So it's usually just an incidental finding, doesn't really require treatment, and they won't really die from it, typically speaking.
Just as kind of like an interesting point more than anything in terms of why the chronic lymphoid leukemia is kind of like a lymphoma, but not really, is because how lymphomas are kind of classified is based upon like what specific cell in the lymph node is mutated. For chronic lymphoid leukemia, in the lymph node, it's the memory B cells. But from immunology, memory B cells will run around the whole blood system and do their job. And so therefore, even though it's kind of like a lymphoma because it's originated from the lymph nodes and will therefore cause a lymphadenopathy, it will also kind of cause a leukemia picture because those cells naturally would have liked running around in the blood anyway. And that's kind of like why that's kind of thing. But it's kind of indolent as a process. That's kind of a fun fact, I guess.
Yeah. Cool. So that's the leukemias. And then we'll move on to the myeloproliferative ones, or the myelodysplastic syndromes. So malignancies of these myeloid cells. There's 4 of them, but one of them is CML. So we've already talked about that one. Essential thrombocytopenia. So this is overproduction of platelets, and the key is that it's overproduction for no good reason. So essential thrombocytopenia, like essential hypertension, is like there's no explanation for it. So thrombocytopenia, if you see that on like a blood test, it's not really a problem in and of itself because it could be secondary thrombocytosis. So you get overproduction of platelets in response to things like infection, inflammation, and bleeding. Essential thrombocytopenia, however, requires that you rule out secondary causes. And so you're saying that there's high platelets, but for no reason. It's associated with these genetic mutations, JAK2 and calreticulin. JAK2 is a big one for all of these myelodysplastic syndromes. And so it's not really unique to ET specifically. Peripheral blood film would show big clusters of platelets like this. That's pretty sort of in your face. And then the bone marrow biopsy, hypercellular but large immature megakaryocytes. So remember, they're the types of cells that are like the predisposed, oh no, that's not the right word. They're the precursor, that's the word. They're the precursor to the thrombocytes. And so these are the ones that you'll see in the bone marrow. And then the key features, so you would think that with lots of platelets that thrombosis would be the main issue, and it is. So they can get TIAs, strokes, AMIs, basically clots in places that they shouldn't have clots. But they can also have paradoxical poor clotting because these platelets are like immature, they're not proper, and they're not functioning as they should be. So they can actually get hemorrhage as well. So it's sort of either end of the spectrum. And then the other one is erythromelalgia, which is basically where these platelets clot in tiny vessels. And so they get like red, painful extremities, like the tips of their fingers and things like that. Polycythaemia rubra Vera. So this is if it's proliferation of red blood cells, and again associated with the JAK2 mutation. The peripheral blood film would show lots of microcytic hypochromic red blood cells. I just think of it as like, again, it's kind of an immature thing. Like if we're overproducing red blood cells, then you don't have enough like iron and hemoglobin to distribute between them. So they'll be small and hypochromic. Plus or minus elevated platelets. So with this one, the red blood cells are the main problem, but you can actually have increase in the other cell lineages as well. And the platelets would probably be the main one. So your key features can be divided into stuff caused by elevated red blood cells and stuff caused by elevated platelets. So having lots of red blood cells gives like a flushed appearance, gout from increased turnover, but really the big buzzword is itchy after a hot shower. So if someone comes in and like they say after they hop out of the shower, they're really itchy all over, it could be Polycythemia rubra Vera. And then the symptoms of increased platelets are same as for essential thrombocytopenia. So either paradoxical poor clotting or thrombosis or both, and erythromelalgia. The other one that's part of the diagnostic criteria is decreased serum EPO. So EPO, remember, is produced to stimulate the production of red blood cells. So if you have lots of red blood cells, then it makes sense that negative feedback would cause decreased serum EPO. And then lucky last, if everything is messed up, it's primary myelofibrosis. So this is bone marrow fibrosis leading to failure everywhere. So it's associated with JAK2 again. And the keywords are a leukoerythroblastic peripheral blood film. So that means the leuko and erythroblastic. So immature white cells and immature red blood cells. So immature white cells, we already know what they look like, the big blasts. The immature red blood cells, they have like abnormal shape and abnormal size. So that's anisocytosis and poikilocytosis. And the other one is teardrop red blood cells. Again, part of that sort of immature red blood cell weird shape kind of category. And then on bone marrow biopsy, you get a dry tap. So nothing comes out because you've got fibrosis in the bone marrow. Key features, I've listed them here. So again, similar sorts of things where like you've got lack of production of all your cells. So you'll have anemia, bone and joint pain because of the loss of the marrow, constitutional symptoms because it's a blood cancer, dry bone marrow aspirate, we've already mentioned, extramedullary hematopoiesis. So remember, if your cells can't be produced in the bone marrow, they'll have to be produced elsewhere in the liver and the spleen. That's your secondary sites. And so you get enlargement of those organs. And then fatigue, that's kind of part of constitutional symptoms, but it's actually the most common presenting complaint for this, and gout from increased cell turnover. And then lucky last, we have the lymphomas / multiple myeloma, because I threw that in with this group as well. So this is malignancies of this kind of branch, T cells, B cells, plasma cells. So Hodgkin's lymphoma versus non-Hodgkin's lymphoma. It all centers around the presence of these cells here. They're called Reed-Sternberg cells, and they kind of look like two eyes or two fried eggs, is how I see it. And the presence of that cell makes it Hodgkin's lymphoma. If that cell is absent, then it's non-Hodgkin's lymphoma. That's the differentiation. The features, however, like are pretty similar. So you'd get painless lymphadenopathy, and importantly, it's like rubbery, mobile, enlarged lymph nodes that are painless, because if it's painful, it's more likely to be enlarged lymph nodes due to infection, whereas painless lymph nodes is more likely to be cancer. Most commonly, it affects the cervical and supraclavicular sort of chain, so up here. And then rarely, if they're really large, it can cause SVC syndrome, so obstruction or occlusion of the SVC, or pleural effusions even. You also get B symptoms, as is classic with all the blood cancers, and hepatosplenomegaly, also kind of classic for the blood cancers. One of the weird buzzwords, I guess, is tender lymph nodes with alcohol consumption. That points to a specific kind of Hodgkin's lymphoma. So if that's in the question stem, it's Hodgkin's lymphoma. They're also associated with a past history of EBV. Non-Hodgkin's lymphoma is a little bit more complex because it's basically just the catch-all for everything that doesn't have this specific type of cell. So there's really many, many types of non-Hodgkin's lymphoma. I think there's only a key handful that you actually need to know. And really Burkitt's lymphoma is probably the main one because it's very buzzwordy. The majority of these rise from B cells. T-cell lymphoma is actually less common. And then, yeah, Burkitt's lymphoma would be the main one to know. So this is that classic massive submental and submandibular lymphadenopathy. So they come in with this massively deformed kind of jaw. It's associated with specific gene mutations, but really the main association to know is EBV and chronic malaria. HIV as well, but that's sort of less, that doesn't come up as much. That's a very aggressive lymphoma, but there's a whole spectrum of lymphomas from very indolent to very aggressive. And probably the main indolent one to know is follicular lymphoma. So this is a follicular lymphoma. And the reason it's called that is because you can see it kind of looks like little like discrete follicles in the architecture. So that kind of picture points to a follicular lymphoma. And this is very indolent and very slow growing, doesn't often cause symptoms until quite down the path. And so when people present, they'll often have widespread lymphadenopathy, like all over the body, because it's progressed so slowly and so gradually. Follicular lymphoma, however, can progress to an aggressive lymphoma, and that's diffuse large B-cell lymphoma. And that's this kind of appearance. So you can see it's just absolutely jam-packed with B cells. That's sort of the classic picture there. And they just get more rapid onset lymphadenopathy. Even though we say aggressive, aggressive refers to like how rapidly the cells are dividing. It can actually still, it's not really necessarily a prognostic indicator. So these can actually still be curable. And because they present more like earlier, because of the more rapid lymphadenopathy, they're actually quite treatable. And then mantle cell lymphoma I threw in because it's like the third most common lymphoma after these two, but I really don't think you have to know much about it. If it did come up, the buzzwords would be that it's overexpression of cyclin D1, and it happens to cause mucosal polyps in the GIT. But I think this is sort of like decreasing order of yield. Like Burkitt's lymphoma, if they were to examine lymphoma, it'd probably be this one. And if it was anything else, I would probably guess follicular. This would be your main aggressive non-Burkitt's lymphoma. And then lucky last is multiple myeloma. So this, again, very buzzwordy. So this is expansion of the plasma cells, specifically the differentiated B cells that are secreting antibodies. On peripheral blood film, you see rouleau bodies, so which is this sort of like stacked appearance of red blood cells. And the key features are CRAB, so hypercalcemia, renal failure, anemia, and bony lesions, typically presenting as lower back pain. Basically, they get these like lytic lesions, little holes in all of their bones. So that would be in the skull. And in the pelvis area here, you can see again, there's like little holes everywhere. So they're more prone to pathological fractures. So someone might present with a fracture and also happen to be anemic and have signs of renal failure. And you'd have to start thinking about multiple myeloma. Not diagnostic, but another buzzword is Bence-Jones proteins, and that's found on urinalysis. Any questions about that before we just quickly whiz through OSCE/clin skills? Feel free to type in the chat. If not, we'll move on. So, heme history is not very long, but when I was learning it in second year, I was like, it's such a random constellation of questions. Like, what is the relationship here? They all seem like very all over the place and non-specific. So I've tried to categorize them again into like your clinical features of the different specific cell lineages. So you start off with the general B symptoms: fatigue, fever, night sweats, weight loss. That's going to be sort of non-specific for really any of the blood cancers. And then you start looking at the specific cell lines. So you've got your white cells, you've got your platelets, and you've got your red blood cells. So if they've got a white cell problem, they're going to be more prone to infections. So you'd ask about frequent infections, difficulty recovering from infections, and specifically opportunistic infections like thrush. If they've got bad platelets or not enough platelets, they'll be very prone to bruising and bleeding. So you ask about easy bruising, easy bleeding. Easy bleeding, apparently one of the best questions to ask is if their gums bleed when they're brushing their teeth. And then anemia, your classic anemia symptoms, dyspnea, palpitations, dizziness. You've already covered fatigue from the B symptoms. And then there's a couple other ones thrown in that are kind of, I think, pointing towards more specific blood cancers. So bone pain, you'd start to think more maybe about multiple myeloma. And then lymph node enlargement is pointing you towards lymphoma. And again, it's important to determine if it's painful, because that's more likely to be a response to infection, or painless, which is a bit more concerning. The heme exam is it's kind of, I've said it's basically the GIT exam plus some lymph nodes. So you do like the abdo exam, and then you also do like all the lymph nodes of the body. So with general inspection, you look for body build if they're cachectic, and then you kind of look for signs of anemia. So if they're a bit short of breath, maybe anemia. If they're a bit pale, maybe anemia. And if they're jaundiced, maybe it's a hemolytic anemia, but like very non-specific, obviously. Looking at the peripheries, there are some buzzwordy things for iron deficiency anemia. So that's koilonychia, which is like the spoon nails. That's like specific for iron deficiency anemia. And then cap refill as well. In the hands, pale palmar creases would again look for anemia. And if they're warm and sweaty, maybe you're thinking like Polycythaemia, Rubra, Vera, or something like that. On the arms, you look for petechiae and bruising. That's going to point towards platelet problems and scratch marks. Pruritus, remember basophilia was one of the symptoms in that list. And then you sort of go head to toe. So starting at the face, you look in the eyes for icterus and pallor, as you pretty much always do. And then in the mouth, thrush on the tongue is opportunistic infection. Gum hypertrophy and glossitis as well, and ulcers as well, actually, point to nutritional deficiencies that might be causing anemia. It's very anemia focused, as you can see. And then you start doing lymph nodes. So you do the cervical lymph nodes, you do the epitrochlear lymph nodes, which are just sort of at the elbow here, and you do the axillary ones. I've got pictures on the next slide. You also have to do the para-aortic and popliteal, but I sort of do those once I get to the abdomen and the legs, and you mention the inguinal, but don't do it. One that I always forgot is tapping for bony tenderness. So tapping over the spine, tapping over the clavicles and the sternum as well to see if there's any bony tenderness. That's going to point you towards multiple myeloma or potentially some kind of like bone marrow fibrosis. And then you get to the abdomen and you kind of do like a full abdo exam. So you inspect for skin changes, you palpate the 9 areas, you palpate and percuss the liver and spleen. Remember, hepatomegaly and splenomegaly are important in heme. And then like you auscultate. These ones were listed in the Clin Skills book, but they're kind of like, I don't know if they actually exist. So renal bruise definitely, but I'm not really sure about a liver rub or a venous hum over the spleen, but you'd pop your stethoscope over those areas and say that's what you're looking for. And then you would palpate for the para-aortic lymph nodes, which like you're never going to feel. You'd be lucky to feel any kind of lymph node in like even this area, let alone the para-aortic. They're very deep, probably not ever going to be palpable. And then the legs, petechiae, bruising, scratch marks, same as the arms. You do the popliteal lymph nodes just in the popliteal fossa, and then you feel for pitting edema. And that's all. Here's a little picture of the lymph nodes. Cervical, I'm sure you're already very familiar with from like the RESP exam and everything. The epitrochlear nodes are here, just kind of on the medial side of the elbow, a little bit above the joint. And then your axillary lymph nodes. So you just take your hand and you literally just pop it into the axilla, and you're feeling, so you feel anteriorly, posteriorly, and then you do like, you stick it right up to get the central ones. And then also on the arm slightly, so actually not quite in the axilla for the lateral nodes. And then you do the infraclaviculars as well. Any questions about that? I think that's all for me. If not, I will stop screen sharing.
Yeah, and we move on to immunology. There's a little bit of overlap because cancers and blood cancers were a little bit in immunology, but that's not the bulk of it. So if there are any questions, just feel free to put them in the chat and we will get to them as quick as we can. But if not, we'll get started. So immunology on the broad spectrum of things isn't the most high yield of topics, I'm going to be honest. There are some bits which I'll flirt past and some bits where I'll be like, this is a bit dumb that you have to know, but just know some keywords and you'll get through it. Which is kind of the start, I'm going to be honest. There's also some bits that are kind of important, such as the hypersensitivities and the drugs at the end. So pay, I guess, specific attention to those, and I will try and emphasize things that are more important. But let's get started. So immunodeficiencies. So there are, I guess, kind of two groups, so primary and secondary immunodeficiencies. Primary are the ones they talk about most because those are the kind of weird and wacky conditions you can get. Basically, they're rare congenital disorders that present quite early with just multiple infections. As you imagine, if they have a terrible immune system, they're going to get infections. And it's mostly caused by mutations to recessive genes. They're commonly X-linked. And I guess the gist of this point or this slide is really they can be presenting quite various different ways. And even the same disease can present differently because of random mutations. But we'll get to the specific types of them in a later kind of slide. But yeah, this slide just kind of talks about random mutations you can get. Now, secondary immunodeficiencies are a little bit more, or a lot more common in hospital settings, and I guess they're very prevalent. But you can get infections such as HIV, measles, and malaria that can cause you to have immunodeficiencies. Malnutrition can cause it. You can have cancer that can cause it, such as the ones that Lena was just talking about. So those blood cancers will cause you have an immunodeficiency. But also the medical treatments we use to sort of treat cancers in general or rheumatological sort of diseases will also have some form of immunosuppression because that's kind of how those diseases sort of progress in the pathophys. So if you go through chemotherapy, radiotherapy, immunosuppressive drugs, which we'll talk about later down in the slides, this will also cause some form of immunodepression, making you predisposed to infections. But some general features of immunological diseases, and I think these are primarily resemble kind of what these cells were treated anyway. So this is a kind of point in notice. If you have a B cell deficiency, your consequence will be you'll have more bacterial infections because your B cells producing those antibodies are mostly targeted towards bacterial infections and things like that. Your T cell deficiencies will have viral or intracellular microbial infections. And the cancers as well, because that's what T cells and killer T cells used to try and do. As such, if you have a deficiency in those, that's what will cause. And therefore, in the innate immune deficiencies, those are a little bit more general because they're a little bit more defensive against a whole range of things. And so therefore, you'll get an increase in pathogenic or bacterial infections, just bacterial infections really, but also other factors as well. So it's a little bit more broad because the innate immune system is a little bit more broad in its purpose. But let's get into a couple of these diseases. So these diseases, like I hated them last year, and if I'm going to be honest, I didn't learn them all that well last year, and then they came up on the exam and bit me in the butt really hard. So like know some keywords about what each of them are kind of on about, kind of how they work and what their pathophys is, because they can and very well did come up. I think it was like 3 questions last year, which was a bit ridiculous in my point of view, but like whatever. So chronic granulomatous disease is an undue susceptibility to persistent bacterial and fungal infections in the first 2 years of life from pathogens that aren't pathogenic to begin with. Basically, how granulomas form is basically they are slowly healing areas because of pathogens that can't be cleared by the immune system. Tuberculosis is something that causes granulomas normally, so not as a product of chronic granulomatous disease. And it's because your immune system can't clear it. And so therefore, like what happens in this kind of chronic granulomatous disease, your macrophages will kind of fuse around it and form like a barrier surrounding it. This will cause pneumonia, lymphadenitis, skin abscesses, visceral infections, etc., and you need antibiotics to treat it, basically. But effectively, what they do is they form granulomas. Now, the reason this occurs is because there's an enzyme called NADPH oxidase, which fails. Normally, how they operate is they are able to kind of destroy cells because of that kind of reactive oxygen species. But in this condition, these cells aren't able to do that. So basically what we're saying is that these phagocytes aren't able to function, which is different to one of the later ones where they can't access. But this is one where they can't function and do their job in killing, if that makes sense. This, on the other hand, so leukocyte adhesion deficiency, isn't a problem of phagocytes working, but rather they can't get to where they need to be. So normally, hopefully you guys remember from first year, selectins and integrins will aid in the ability for leukocytes to kind of migrate and extravasate into the site that they needed through inflammatory processes. Here, leukocyte adhesion deficiency, they lack that integrin. So one of the molecules required for them to kind of exit the blood and into the site where they need to cause inflammation. As a result, they kind of can't get to where they need to be. And that's kind of like not really the buzzword, but kind of the idea behind LAD. There is a type where the selectin is broken instead, but that's a different type. This causes severe recurrent bacterial infections that need antibiotics and hopefully bone marrow transplants. This is from kind of genuine pathogens, i.e. pathogens that would have caused problems in normal people anyway. They're just worse. They're just far, far worse. Can present with severe gingivitis, high white blood cells, normal antibody responses, and delays in wound healing. And I think some of those make sense. So the high white blood cells is because, well, you can't get the cells into the location they need to be, so your body kind of just overcompensates. And if you can't get them there, then you can't heal, and so therefore you get wound healing as well. Okay, so severe combined immunodeficiency, or SCID, is a disease, I guess, that affects the development of T cells and B cells, and presents with few lymphocytes in the periphery with an almost complete lacking T cell-based immunity and T cell antibody response. And it's because of the lack of c-myc development, so the development of these T cells in the thymus due to kind of genetic problems. There are three main branches of this. And I've bolded the things that I really think is important or accessible, I guess. So keep those in mind the most. So X-linked SCID, also known as common cytokine gamma chain receptor deficiency, is because when there's no T cells or NK cells, natural killer cells, the B cells have normal numbers. Due to a problem with gamma chains and stuff like that, but that's one of the three main causes. The other two are your recombination activating genes, or 1,2 enzymes, where there's no T cells or B cells. And basically because the RAG is an enzyme which recombines the functional components of antibodies, and as such, they can't be positively selected without it. And the X is your purine salvage pathway enzyme. So basically, things that allow your purines to be kind of reprocessed, I guess. So there's no T cells, B cells, or natural killer cells, and that's kind of like a triple. So your X-linked SCID is normal B cells, your RAG is no T cells or B cells, and your purine salvage pathway enzymes is none of the above. SCID in general is just a problem with your kind of development of these blood, and you'll get the few lymphocytes in the periphery. And that's kind of, I think, the big or more important thing to think about there. The outcome is that in the first few months, they are protected by maternal antibodies and will be fine for a while before developing severe opportunistic infections, such as a thrush in the mouth or nappy area, so a fungal infection. And that could very easily be the sort of buzzword or situation they give you. They have common coughs and pneumonias from viral infections. And the treatment is, I guess, what you imagine. So prophylactic antibiotics, intravenous immunoglobulins, and just general or better hygiene, not even general hygiene, I imagine. You also don't give them live attenuated vaccines, just because, yes, those vaccines are definitely weakened, but these people have no immune systems, so it's not going to do good. And they will die without this in a couple of months. So it's important that, I guess, this gets treated. Okay, and then there's a couple of antibody deficiency syndromes. And these are, I think, a little bit easier to kind of get. But basically, these are termed X-linked agammaglobulinemias with hyper IgM. And it's because of a problem with isotype switching. Basically, how you can think of it is that your plasma cells will produce IgM as a default. It's your first line of defense. It will do that regardless of what it does. It doesn't need to be anything special with that. Then as your kind of body learns what the pathogen is, which I'll talk about in a second, and it will switch to whatever's most specific, I guess, like most potent to it. You can almost think about it like Pokemon, where you switch to like whatever type is better. They can't do that. And so therefore, they can't produce the IgG, the IgA, or the IgE. And so therefore, they'll produce a lot more of the IgM. Because they are still producing IgM, it's not nothing. They can still do some immunity, it's just not as good. And you also get germinal centers which are lacking because of lack of proliferation. You can also get normal blood lymphocytes, but there can be a neutropenia. But effectively, they are more susceptible to infections because they aren't as effective in their kind of production. And defects in T cell activation. So this is termed an X-linked lymphoproliferative syndrome. There are 3 phenotypes. So fulminating infectious mononucleosis. Basically, infectious mononucleosis is just glandular fever. That's the term. That is just EBV virus infection. So fulminating just means it's a worst case of that. And so therefore it's one of them. You can get B-cell lymphomas or lymphoproliferation because of this, which is what we talked about before, and dysgammaglobulinemias, which is basically problems with how much of the immunoglobulins you produce or less of them. This is related to SAP and SLAM molecules, which play a role in signal transduction, normally expressed on natural killer and killer lymphocytes, T lymphocytes. Beyond that, you can have a read of it, but I don't think it's all that critical that you have an innate or intimate understanding of those molecules, but does not exist in T cell activation disorders. All right, so hopefully that made sense. Basically, for all those conditions, just have a general idea of some of the key features of each, and you'll get one of them as a kind of multi-choice option in your kind of test. Otherwise, it's a bit stupid. Otherwise, those conditions, they're very rare and very pointless, but they kind of assess you. They are surprisingly moderate yield. Cancers. So this is, I guess, a method or a thing they think about when they describe cancers. But basically, as we all know, they are uncontrolled proliferation of cells because of a whole bunch of genetic mutations. These mutations have to have 6 characteristics. And these are surprisingly recognized and surprisingly used, if I'm going to be honest. But they are self-sufficiency in growth signals, insensitivity to anti-growth signals, evading apoptosis, limitless replicative potential, sustained angiogenesis, and tissue invasion and metastasis. And we'll talk about what they mean in a little bit more detail in the slides to come. And the last point doesn't have to serve for immune cell cancers because they are already in the blood. So they have to go into the blood. These can occur from what we've already thought about. So random mutations, environmental factors, so because of your smoking and then your radiation, infections such as HPV for cervical cancer, but also a whole range of other infections for other things, and errors in DNA recombination and chromosomal translocation. Those are just basically mutation errors. Okay, so number 1, your first characteristic. So self-sufficiency in growth signals. Basically, normal cells require signals for mitosis via transmembrane proteins. What oncogenes do is they have a self-sufficiency from these growth signals, i.e. they don't need them anymore. And one of these is a c-myc oncogene, which normally codes a transcription factor on cells that relate to cell division. Normally this stops it, but when impaired, it will lead to unrestricted growth. One of these involved is the Burkitt's lymphoma Alina was talking before. So this is where there's a translocation from a B cell receptor on chromosome 14 with a recombination with the c-myc gene on chromosome 8. Because your B cell receptors or that gene on chromosome 14 will be activated a lot because I guess normally you need to produce antibodies. That combination with the c-myc is going to overexpress that transcription factor that will normally turn genes on, causing cell division. As a result, it causes a hyperproliferation of B cells and causing lymphoma, as the B cells just kind of spam out more cells. The second is insensitivity to anti-growth signals. So normally tissues will have anti-proliferative signals to maintain homeostasis. And these are effectively your tumor suppressor genes. They are normally recessive, so require both to be mutated. It's either two-hit hypothesis that you kind of talked about last year. Sometimes DNA repair genes can also be considered tumor suppressor genes. Now, the most infamous one of these is your p53, and the normal activity is required to activate DNA repair proteins to kind of stop apoptosis. Without it, or mutation to it causing to fail, results in a lot of cancers, and it's one of your most common, I guess, one of your most common anti-proliferative or tumor suppressor genes that are mutated in cancers. Now, evading apoptosis. So this is basically acquiring signals that will allow them to resist the apoptotic signals of other cells. Basically allows the tumor to grow without shrinking from your normal apoptotic signals. So normally what happens is you have apoptotic stimuli, and then it does a sentinel or whatever proteins, that doesn't really matter. But basically they will trigger execution of proteins causing death. There are also another group of proteins called protector proteins. And if you have too much of this protector protein, it will swap your execution of proteins from signaling into death. And effectively, that's what BCL2 does here in follicular lymphomas and a whole bunch of other cancers, where the BCL2 is translocated onto chromosome 18, or so from chromosome 18 onto that chromosome 14, which is another one of those VDJ recombination, or your genes which allow for your antibodies to be more specific to whatever specific thing it is. And that's, again, one of those more proliferative sort of promoted regions, and will cause a result in terms of overproduction of those protector proteins. And will therefore allow for this to evade apoptosis. Now, you can kind of imagine that because it's not really allowing them to grow, it's just allowing them not to die, it might not grow as fast, and so therefore it might be a slower growing cancer. This is a target for venetoclax, but I don't know if that's all that important for you guys. Just knowing that's a thing is probably most important for you guys. This is basically the lack of need of telomerase. So I don't know if it's still Hassan's favorite toy word, but whatever. Cells normally have intrinsic programs which limit the number of divisions, which is termed senescence. And in cancers, that's not a thing. So they have continuous telomeres that keep getting longer and longer and longer. And as such, don't allow for senescence to kind of occur. That's kind of what's going on there. And all right, so we'll talk about this. So this is kind of what we talked about already. So leukemias and lymphomas, and I'll kind of just discuss them quickly. So leukemias are malignant proliferation of bone marrow-derived cells, where the mature cells are found in blood or bone marrow. Basically, you just have cells that are bad floating around your blood. That's the gist of it, basically. And then lymphoma is a tumor of non-circulating lymphoid cells in the lymph nodes, generally. As we talked about before, there is some exception with CLL, where they kind of just go everywhere. Yeah, CLL, I'm pretty sure. But that's a general gist of what leukemias and lymphomas are. And that's kind of like the simple definition that makes sense in your head for now. That will do, because that's all the simple definition I had in my head last year as well. It gets a little more complicated, but it does the job. And then myelomas are simply a malignancy of plasma cells, which is that multiple myeloma Alina was talking about before. They secrete paraproteins, which are basically just monoclonal antibodies. So basically one antibody in mass production. Because if you think about it, myeloma is a tumor of one plasma cell that's gone berserk, rather than in immune responses, which are polyclonal, because it's a whole bunch of plasma cells which have gone reasonably crazy and causing cancers. I got a question going back to the telomere thing and going there. So this one here. So basically what happens with the telomeres, so the question is, how would increased telomerase cause cancer? So basically how this works is it allows the cells not to die effectively. So how normally cells will work, or how genetic mutations or replication will work. So eventually the ends will get shorter and shorter and shorter as the kind of ends of the kind of replication process doesn't meet properly, basically. and that will get shorter, and therefore cause it to become more unstable, and therefore cause it to be basically cause it to become apoptotic, die. But if you have more telomerase, you can just keep adding that on to the ends, and if you keep adding that on to the end and end, it won't disintegrate these ends, and so therefore they will keep surviving, and therefore will not go through senescence in terms of limited cell division, and will therefore keep growing in terms of a huger and larger mass. Does that make sense? Hopefully that makes sense. Cool. If you have any questions, put them into the chat, either privately or publicly. Doesn't really matter for us. Cool. So basically, different malignancies will occur at different phases of the differentiation process. Basically, the summary in terms of how to understand hematological cancers is that they've just given names to a bunch of things they saw down the microscope. And then confused med students with their fancy long-ass names. It's basically just one weird cell has gone berserk, and they've called it follicular lymphoma because that's where it was. That's basically what the thinking is behind it. And they will vary in kind of onset and aggressiveness depending on what that original cell was already doing to begin with. And we can talk about that in a sec. But if you think about it, if you have a platelet problem, you have bleeding problems. You have red blood cell problems, you have fatigue because you're kind of producing oxygen around your body. If you have no immune cells, you have lack of immunity. It's kind of literally that logical, I guess. This is the two cancers they talk about most with, I guess, immunology. So basically the idea is that the more aggressive your cancer is, the more curable your cancer will be. But also the more likely you can die from it, basically. Because, and the rationale behind that is because a lot of our chemotherapeutic drugs will target rapid replication. That's also why it affects your hair, your skin, your GI, and it causes those side effects. But that's also why they're much more effective against your acute kind of cancers. Whereas in your chronic cancers, they aren't as good because they are growing slower, and therefore their replication process is slower. And so therefore the drugs don't have as much of an opportunity to work on them. But because they are slower, they aren't as likely to do damage to you because they're just growing slowly over time. But some key words, as Elaine talked about before, ALL is very common in childhood. CLL is more common in adulthood. People generally die with CLL, rather than from CLL because it is so unaggressive. The symptoms and all that kind of stuff is very similar, and it's characterized by its blast count. So those immune cells or immature immune cells, basically your immature white immune cells, and they kind of progress. That's all blast means, by the way, just immature cells. And they kind of just progress through. In terms of treatments, generally speaking, what we can treat with cancers is surgery, chemotherapy, prophylactic, antibiotics, antivirals. That's just for the immune suppressive effect that we've already had. Bone marrow transplants, because we want to replace a lot of those immune cells with better ones, or with, I guess, more complicated theories in terms of trying to treat the cancers in the immune cells, obliterate everything we've got, and then put them back in. So that's an autologous immune bone marrow transplant, or you get someone else's to do it for you. Or you get granulocyte macrophage colony stimulating factor, I can't speak, which is basically just allowing your immune cells to reproduce better. And immunotherapy, we'll just talk about later. There's a specific kind of trio for CLL called FCR therapy. This isn't even that important for us in third year. So the yield for you guys in second year is low, but that's the triple therapy if you guys are keen or interested in that at all. Just as a note, surgery for blood cancer isn't the most good thing because it's not really that useful because they're already in the blood everywhere. But that's a general spec thing in terms of they can be used for cancers. So immunosurveillance. So for a cancer to develop, the avoidance of the normal immunosurveillance of cancer is important. Basically, what I'm saying here is that your cancer, your cancers, the cancers that develop have to dodge your immune system, which will normally do well in avoiding or killing cells that seem to be cancerous or trying to be cancerous. So patients without an immune system are therefore more susceptible to cancers, such as those with AIDS can develop Kaposi sarcoma, which is one of those AIDS-defining illnesses, which is completely absent in the immunocompetent individual population. They don't really happen in there. You can never say never, but they don't really ever happen. This response is antigen specific and is similar to a normal adaptive immune system. Basically, the response is predominantly from cytotoxic T cells, which help with other random cells. And they recognize either products of oncogenes or mutated tumor suppressor genes. They either recognize the overexpression or aberrantly expressed self-proteins, so your MHC class 1s, which are surprisingly useful to think and know about. So either a lack of them or overexpression of self-proteins, or oncogenic viruses. And that's kind of what they look for in terms of which cells they kill and which cells they don't kill. And this is kind of, I guess, one of the pictures talking about that. So tumor cells, I guess, ingested, and they kind of a co-stimulative response. Just have a look at this picture. I think it's quite good, but I don't know. Some people like it better than others, I guess. So tumor invasion. So how do then these tumors evade the immune system in people who are healthy? So they either will lack antigens a T cell can recognize. So this basically occurs in the immune system will select for mutants that don't express antigen, and those are ones that are killed. And so if they lack antigens completely, then they can't respond really. So tumors will lack MHC class 1. In saying that, your NK cells will also try and do a role here and kind of, I guess, repressing those. So your MHC class 1 will normally inhibit natural killer cells. So the lack of those will also, to some cancers, allow them to kill those cells. And some of the cells will inhibit your T cell activation. So tumors regulate the environment, i.e. they kind of just create their own cytokines and create an environment where T regulated cells will inhibit all the other cells around them. Over time, a tumor cell will combine these three, basically determine what works for them, and evade the immune system as a byproduct of that. And that's kind of how they can evade your immune system. But these are the three kind of methods. All right, so hypersensitivity. So this is kind of the more important ones, or the most important in terms of detail you kind of need to sort of know. So hypersensitivities are injurious or pathological immune reaction. Basically, they just spaz out. And it's either response to foreign antigens, which is what we'll talk about now, or response to self-antigens, which is autoimmunity, and we'll talk about that in a second. But they class into 4 types. So immediate hypersensitivity, antibody-mediated, immune complex-mediated, and T-cell mediated. And these are very important for you guys to know what they are and kind of examples for them, because they are very much accessible. They don't fit in each of these groups perfectly, but they are good enough for us. So immediate hypersensitivity type 1. This is basically your allergic reaction. Your anaphylaxis, your atopic diseases, your food allergies. Basically, they occur in 2 phases. So your sensitization phase and your activation phase. So first, they have to be kind of recognized by the immune system. So causes dendritic cells to drive Th2 self-differentiation, and then they produce IgE, and the IgE will stick onto Fc receptors on mast cells. On second response, these receptors on those mast cells will then respond to antigen and will degranulate, causing that kind of anaphylactic or atopic reaction. That's kind of classical of immediate hypersensitivities. They are, I guess, effectively dependent on the mast cell. That's the kind of most important cell that you'll find. So these are found in connective tissues, and they're most abundant in the submucosa and the dermis. And on the surface of mast cells are these Fc receptors, which I just talked about, which respond to these IgE antibodies. They will cause the secretion of mucus and smooth muscle contractions in allergic diseases. And that's kind of, I guess, a picture to kind of demonstrate that concept. Th2 cells will drive this kind of immune-mediated hypersensitivity. And these are responsible for your weep and sweep response for helminths. So your Th2 response will secrete IL-4, 5, and 13, which will target helminths. Th1 will secrete IFN, so interferon, targeting intracellular microbes, and Th17 will target or secrete IL-17A and F, and 22, targeting extracellular microbes, so your parasites and things like that. So those, I guess, sorry, not your, like other cells, your bacteria and things like that. So these, I guess, are ways in terms of how your immune system will kind of change itself to kind of respond properly to things. Your normal Th2 response is designed to deal with helminths, so kind of your parasites and things like that. It's called the weep and sweep response. So weep is the kind of extra production of that mucus, and sweep is the kind of the hypersensitivity of your smooth muscle to kind of get rid of it out of your system. So therefore, the idea is to expel the lumen of worms and things from the lumen of your GAT and respiratory system, but it also causes your asthma, things like that. There's this kind of theory, I guess, where the Th1 cells and Th2 cells are in a paradigm or a balance. Effectively, what it's talking about is that in kind of, I guess, society, when you have more atopic diseases, your Th1 response is upregulated or your Th2 response is downregulated. And as a result, you have more of an allergic response and a more of a hypersensitivity. It is thought to some degree that the hygiene hypothesis or your environment will play a role there, but how much that plays a role is up to research, I think. But basically, you just need to know this kind of thing is what they're thinking. Basically, which one you have more likely dictates which clinical response you're going to have. And so therefore, what you're thinking is you can kind of shove it towards a Th2 response or kind of balance it towards your Th2 response to kind of reduce these kind of immunological sort of diseases. Oh, sorry, Th1 response. Cool. So the treatment for allergic diseases are as follows. So pharmacotherapy, your antihistamines, your beta-2 agonists, and your corticosteroids, basically to kind of counteract that kind of degranulation effect that you just had, as well as dilate your can't see the word, respiratory kind of lumens to make them open up. You can also have corticosteroids, which in general just decreases the inflammation in general. That's kind of a mass solution. Then you have your antigen-specific one. So either you can just avoid the allergen you're allergic to, that's pretty obvious, or you can have immunotherapy designed for that specific allergen, i.e. what happens is that you get exposed to that over and over and over and over and over again, and then because you're exposed to it in a small amount, it kind of shifts that paradigm to reduce that Th2 response and give you a Th1 response instead. This is semi-theoretic, semi-useful for some allergens, but not for all, and it's something you can think about as a potential theory, or that's practice, but that's how that practice will work. Okay, so your type 2 immune responses. So these are your antibody-mediated hypersensitive responses. These are responsible for Graves' disease, myasthenia gravis, vasculitis, and autoimmune hemolytic anemia. They all work on the same kind of process, i.e. you have free-floating antibodies, and they will direct themselves to a cell surface and therefore cause a problem when they bind. So these interact with Fc receptors on natural killer cells, and all that kind of stuff. Basically, they will act onto cells, bind to cells, and that causes them to, I guess, respond to natural killer cells in your immune system. This will, to some degree, affect your complement. So complement is a collection of circulating serum proteins made from your liver, as all proteins really are. They can allow for inflammation, opsonization, and bacterial lysis by themselves. They're activated through 3 pathways: the alternative, your lectin, your classical. They are there in terms of more detail for your own reading, I guess. And these are found on phagocytes and mast cells, and they are part of your immune system to try and, I guess, counteract problems. Now, this type 2 hypersensitivity is contrasted to type 3, which is similar, but instead the immune complexes of antibodies and circulating antigen deposit in tissues, which result in complement and Fc receptor activation. Whereas before, they were just, except for being free-floating, they are bound to a surface. Does that make sense? Hopefully. So type 2, they're kind of free-floating, they kind of do things. But in type 3, they are bound to surfaces and therefore will cause problems because of that bound effect. So in SLE, your glomerulonephritis, your drug allergies, and your serum sickness. One of the ones we'll talk about now is serum sickness. So this is basically a type 3 sensitivity to penicillin. What will happen is you have a deficiency of complement as it's kind of being used as these things are deposited onto kind of cell or like your skin and other vessels. They can cause puffy eyes, widespread urticaria or rash, wheezing, fever, swollen joints, and lymphadenopathy. You also get hives due to the kind of degranulation response as well as a rash. They're given prednisolone, so basically the immune system just gets turned down and taken off antibiotics. That's kind of the cause. So yeah, I think you can get hives in type 1. I don't know if you can get type 2. Type 2, you don't really get hives, I don't think. Alina can correct me if I'm wrong. But the question is, do patients get hives in type 1 and type 2 sensitivity 2, since they're mast cells and they're subsensitivity 2? You can get them in type 1 because they're just allergic reactions, realistically. Type 2, I wouldn't really think you would. And it's more so that it's like these conditions give you type 2. Think about it as an antibody binding to something else. So for Graves' disease, you guys should know fairly well. And that's an antibody binding to a TSH receptor. That's kind of what's causing Graves' disease. Autoimmune hemolytic anemia, which JJ talked about yesterday, is literally an antibody binding to that red blood cell. So it's probably not likely to give you a hive or rash, I'll be honest. Cool. All right, so type 4 is basically nothing to do with your antibodies. This is responsible for contact hypersensitivity, type 1 diabetes, multiple sclerosis, allograft and allograft rejection. MS is multiple sclerosis. These are when your Th1 or Th17 cells activate macrophages and neutrophils and basically lyse cells through cytotoxic T lymphocytes. That's kind of what's going on. There's no antibodies at all here, and this is kind of when you're thinking about a disease where it's caused by one cell killing the other cell. That's what this is. An example is poison ivy, which is the weirdest example because they could have wanted the diabetes, but this causes raised red elongated blisters. And instant antihistamines will have no effect because it's not related to that kind of degranulation effect. What it actually is because what poison ivy sort of does is it kind of basically binds this hapten molecule or binds this kind of molecule onto your normal proteins. What that will do, and your haptenated self proteins will look different to your normal cells, your normal immune system cells. This will therefore activate your Th1 cells, causing cytotoxic T lymphocytes to come out and basically kill your skin. And so therefore, it's not really a result of any kind of antibody response. It's because that singular cell is responding to that particular antigen that poison ivy has caused change. And that's kind of what's causing this to occur. Okay, and autoimmunity. So autoimmunity is an adaptive immunity specific for self-antigens in the form of hypersensitivity. So tolerance is a normal concept in your body, and it's basically the idea that your body can tell who's normal and what's not normal. And it's important because you can have a lot of kind of diversity with the kind of immune antibody receptors that you kind of already have. And as a result, these antibodies will just kind of be made normally. Now, central tolerance means that these self-reactive lymphocytes, that some of them are produced, are deleted during development, which will cause a smaller pool of naive T cells, which will then go under more selection to get kind of matured and refined further. So central tolerance aims to remove the high affinity anti-self lymphocytes. And it's important they don't get rid of too many because otherwise it will impair your immune response. So how do they get rid of the other ones? Well, they go through 4 processes. Either antigen segregation, so i.e. they just physically can't get to where those other weird places are, so your eyes and testes. Peripheral energy, i.e. if they kind of produce a weak response instead of a strong response, they're turned off. Regulatory T cells, i.e. they can just dampen them because of cells. Or activation-induced cell death. So if they are always active, I think the body kind of just thinks, well, this is kind of dumb. Unless we have an infection all the time, they'll just turn it off by doing that way instead. So these are also, I guess, positions where you can develop autoimmune sort of diseases. Now, specific diseases are poorly understood. But basically what we think is you have kind of predispositions to certain autoimmune diseases because of your genetics. So diseases have certain HLA or MHC sort of associations, and this is what presents to antigens and thus will trigger such reactions. So this is your rheumatoid arthritis, this is your ankylosing spondylitis, which are HLA B27 sort of associations, and they will cause effects there. Females always tend to develop autoimmune diseases more, and your family history is also significant. Single gene defects can also cause it, and as listed sort of below. You can have a look at those in your own time. They're not that important. So development of autoimmune diseases. So there's kind of 3 ways that can kind of happen, or 3 different ways that happen that aren't genetic. So either you can have breaching of those immunological privilege sites that we were talking about before. So for instance, if you break your barrier to your eyes or to your testes or to other immunological privilege sites, basically it allows the T cells that were once blocked to get in and cause type 4 autoimmunity. You can get stress-induced post-translational modifications, causing cells or causing proteins to become citrulinated or create neoantigens. This is what happens in sort of RA, and it's kind of, you can think about it similarly to what happens with poison ivy. Basically, just tag something on and then cause an immune reaction. Or you can have infection and molecular mimicry. Basically, your normal antigens that you already produce towards a bacteria or something like that look very similar or weirdly similar to what you have naturally in your own body. This happens with Streptococcus in rheumatic fever, where they cross-react with your heart valves, causing rheumatic heart disease. This can also happen for other diseases such as Klebsiella, Angst-Pond, and Campylobacter with GBS syndrome. All right, so we'll talk about type 1 diabetes quickly, I guess, mostly on the immunological point of view though. So this causes the polyuria, polydipsia, polyphagia, involuntary weight loss that we talked about before. And this is caused by your CD2 lymphocytes targeting your beta cells. This is because of autoantigen responses to insulin, protein tyrosine phosphatase, and IGRP. Basically, they just target these cells and they cause beta cells to die. And eventually you're going to need insulin, otherwise you will die. And I think that's all I'll touch on here in immunology because the rest of it's talked about before. Rheumatoid arthritis is a disease localized to joints that will affect females more than males. Effectively, there's an establishment of a chronic inflammatory environment in the joint, either it's a pannus, leading to a cartilage destruction. This is associated with HLA, not to be 27, so like a DQ something, and is also just to have a T cell involvement. These will destroy the matrix metalloproteinases and will chronically activate a rank. So one of those things in your bone, we talked about last time, which destroys bone. Basically, there's no cure, but you can treat the kind of immune response and kind of downgrade that immune response. But that's effectively what rheumatoid arthritis is. And these are some characteristics. So severe joint inflammation, increased synovial fluid, and thickened synovial membranes, so thickened membranes and increased fluid. Destruction of the bone and cartilage because of that chronic rank activation. Activation of macrophage T lymphocytes and elevated levels of TNF alpha and IL-1 and 2. Basically just a chronic autoimmune disease. You can also get something called lupus. So this is a condition where you have diseases of circulating complexes of DNA and anti-DNA antibodies. This is a type 3 hypersensitivity reaction and will classically present with a butterfly rash. So if you look in this picture here, the butterfly rash is crossing over the kind of nose, and it's kind of the classic sort of rash there. It can also cause other rashes other places. So this is and how it causes this kind of disease, because its immune complexes will lodge in a variety of different places. It will cause a glomerulonephritis and vasculitis by itself, as these kind of immune complexes lodge and activate complement and kind of do damage and inflammation that way. TLR9 and BAFF play a role in the pathogenesis of SLE. As you can sort of just have a read there. I don't think it's all that critical. And this is managed with corticosteroids, immunosuppressants, and biologics to get through. But frankly, the most important thing to notice is a type 3 hypersensitive reaction with a classic butterfly rash. That's kind of how you know it's SLE at your age. And myasthenia gravis and Graves' disease. So these are two completely different conditions. So I just put on one side. So myasthenia gravis is a neuromuscular autoimmune disease where you have type 2 hypersensitive antibodies against acetylcholine, interrupting neuromuscular communication. Classically, we present with drooping eyelids because your sort of acetylcholine receptors don't work anymore. And your Graves' disease is caused by an activating autoantibody against the thyroid-stimulating hormone receptor, leading to overproduction of thyroid hormone. And this is a type 2 hypersensitive reaction, and it can also cross-present into the child. So immunization and immunotherapy. So we're almost there. So antibodies and their types. So antibodies are either secreted or expressed on the surface as B cell receptors. B cells produce 5 antibody types, each with a different constant regions, and each with different purposes. So IgD is receptor of naive B cells, but they're not really that useful or important. IgM is the first antibody secreted in the active immune response, and they have a good affinity, a low affinity, but high avidity. Basically, they have a lot of responses and binding sites. You can also get IgA, and there are 2 subclasses of IgA. There's IgA1, which is the most abundant, and IgA2, which is found in secretions. IgA1 is pro-inflammatory, IgA2 is anti-inflammatory, and that's kind of why it's in those secretions. These don't activate complement, but are good at general neutralization. Then there's IgG, which is 4 subclasses, but they are most common in serum and they are activated later down the line, and they kind of showcase better immunity. And then your IgE, which is your target for helminths, but also causes your allergies and things like that. Basically, the more response or exposure you have, the better response you will get. The stronger and faster your responses will be. Cool. There are 3 sort of immunoassays, so basically ways to kind of measure your immune response. But as a general principle, your IgM will always be your first infection and your marker of initial infection, and IgG will be a marker of subsequent infection or kind of more prolonged immunity towards it. Your precipitation-based assays is basically they are combined and they form precipitate. Basically, they concentrate down to a kind of point. There's your agglutination-based assays, i.e. they will clump together instead of forming a lattice crystal sort of structure. And that's basically the same sort of mechanism whereby they just look at what's come out, and if that's what's come out is kind of significant, then you have that kind of antibody present. You can also get labeled antibodies, and these are radioactive enzymes, ELISA or fluorochromes. ELISA will take a specific antibody in the patient's serum, and as such, that antigen has to be known. The platelet is first coated with that antigen, so that's these red dots, and then it's kind of washed out to kind of get rid of all the extra ones. This is a washout. You then have antibodies bind connect to them, and you put those, I guess, the patient's antibody in. And if it's present, they will be connecting to these kind of antigens over there. These are then washed out again, and the fluorochromes or extra chromosomes are added on with kind of a color attached to them. If they have a color attached to them, they will add a substrate and they will change color, which will therefore cause this serial dilution. The more intense the color, the more antibodies will be in the syndrome or in the serum in general. And they will kind of dilute. And the further kind they go, this dilution process, the more they will be. But that's kind of how ELISA will work. So how do they make these antibodies? So antibodies have a high affinity for a specific antigen. And I guess generally speaking, they're generalized by immunizing animal models, producing a specific antibody response. This, however, produces a polyclonal sort of process rather than just one. That's kind of annoying because you don't really want that polyclonal stuff. So what they can also do is you have monoclonal antibodies, where one antibody is produced from a single B cell, and this is done through forming hybridomas. Basically, you have a tumor cell and an animal forming kind of plasma cell. They are formed together to form that one specific antibody, and then they kind of just mass produce as that tumor would normally do. They mass produce that one monoclonal antibody, which is what we then use for treatment, but also for diagnosis. So kind of use of monoclonal antibodies. So they're used for immunohistochemistry, so basically targeting a specific antigen for diagnosis of disease, if it's kind of there to target and kind of match. Immunofluorescence, i.e. you tag them with fluorochromes, i.e. you put a color on the end of them, and if they attach on, they can bright up and look cool. Flow cytometry, i.e. you put them through a fancy laser machine, which is not actually that fancy, which will mark cell populations with that fluorochrome as other things. So if it connected to that CD20, they will be a specific type of cell, for instance. And therapeutics. So they can be given as IV or IM injections, where basically you just give them the antibody that we wanted to give them in the first place. They can come from mice or chimeric, so mice and human, or they can be from human themselves, and that's generally the best if they're just from humans. So monoclonal antibodies as therapeutic agents. So there are 2 targets for monoclonal antibodies, either cell surface molecules, which deplete target cells to antibody-dependent cellular cytotoxicity. Basically, they fuse NK cells on Fc receptors. They're used in chronic lymphocytic leukemia, and that is what rituximab is. Or they can modulate the function of a target molecule, i.e. they bind and they antagonize or agonize to a target, which is what rheumatoid arthritis has with monoclonal antibodies blocking TNF, blocking those kind of production. It's used as methotrexate, but that's kind of more detail. All right, so T-cell activation. So T-cell activation occurs through 2 signals. Signal 1 is through a TCR-CD3 receptor, which recognizes MCHC peptides, and signal 2 is through CD28, which recognizes T cells. This binds to CD80 and 86, which only present APCs, and this is the go signal for T cells. Kind of, I guess, what's I don't know if it's more useful, more interesting, but what they kind of look at more is your break signals, which I think is more complicated. And there are two break signals, generally speaking, for CT cells activation as well. There's your CTLA4 and your PD1. So these are both negative regulators of T cells, and there's a ligand for both CD80 and 86, similar to CD28, with a higher affinity. These are expressed to prevent chronic activation, and basically they stop these T cells from chronically activating, doing their job over time. Sometimes you don't want that to happen, so there can be monoclonal antibodies to prevent that from happening. PD1 is similar, and it's basically doing the exact same thing, and is a checkpoint to prevent chronic activation through these kind of processes as well. Tumors are also regulated in the environment by secreting these immunosuppressive cytokines. The tumors may also suppress PD1 to suppress these T cells, and blockage of these kind of structures, I think I should say 4, not 1, may result in kind of improved outcomes as you sort of limit the sort of suppression of these kind of break signals and allow T cells to do their job for more time. Okay, so this is the last little chunk. This is the pharmacology. So immunosuppressants are used on a whole range of diseases where there's immune response against themselves. So autoimmune diseases, as listed, or organ transplantation acute rejection diseases. They will increase the risk of infection or malignancy because of the general system or the general effect of your immune system has in any way. So your infection, because, well, your immune cells will normally have a problem, and your malignancies, because your immune systems will have a control against your malignancies, and therefore if you suppress that, you will lose that. And that's your general side effects of these, all these immunosuppressants, really. Okay, but this is a quick word on chronic acute versus chronic inflammation. Basically, the time step is kind of the separator, so minutes to hours versus weeks to years. The cellular infiltrate's important because this is the word they'll use most of the time. So neutrophils are always the early ones, macrophages and lymphocytes are the later ones. These are mediated by cytokines and chemokines, things like that. Whereas this is from TNF alpha, as well as other kind of cytokines. These are caused by your viral infections or persistent infections or prolonged exposure to toxic agents, which will cause that kind of chronic inflammation. But these kind of cellular infiltrates, the most important thing for you guys to really recognize and remember. This is a kind of a diagram of the same thing with a little bit more detail, I think. So types of immunosuppressants. So early immunosuppressants, which we still definitely use, basically just stop every single cell from proliferating. There's your methotrexates, your 6-mercaptopurine, and your cyclophosphamide. But I guess more novel ones aim to block specific groups, and these are in 5 groups. So your IL-1 production, so corticosteroids, IL-2 expression, so tacrolimus and cyclosporine, IL-2 signal transduction, your sirolimus, your T cell proliferation, your mycophenolate, and your anti-cytokines, so your immunosuppressant antibodies. And we'll talk about each of those in a little bit more detail as we go through. So IL-1 production inhibitors, or your corticosteroids, these will work in 2 ways. So first, they upregulate synthesis of anti-inflammatory regulators, your annexin-1, which inhibits antiphospholipidase A1. They will also complex as pro-inflammatory transcription factors, resulting in inhibition of binding transcription factors of DNA, repressing cytokine synthesis. So I don't have a picture, unfortunately, but basically they both upregulate anti-inflammatory responses and downregulate inflammatory responses by reducing cytokine synthesis. And that's kind of the 2 ways in which they work, which is important. An example of this is prednisolone, used for rheumatoid arthritis and other kind of things, and inhibits IL-1 and TNF alpha production and gene expression through that second kind of process. It also has, I guess, this is a thing, anti-inflammatory potency to cellular retention potency. Basically, it's how much of a mineralocorticoid it is, and it's not very much of a mineralocorticoid, but that's not that important. Your adverse effects is the Cushing syndrome. So amongst other things, amongst a lot of other things, you get susceptibility to hypoglycemia and osteoporosis, your growth suppression, muscle wasting, hypertension, and your risk of infection is increased, alongside your other things, your moon phase, your buffalo hump, your supraclavicular fat pads, your bruising, your stretch marks, your hyperpigmentations, things like that, your hirsutisms, things like that as other factors. Your calcineurin inhibitors. This is your inhibition of IL-2 expression, and this one I do have a picture for. Yes. So two types. So cyclosporin and tacrolimus. They are used for different things, which is important to kind of choose, I guess. So this is used for acute prophylaxis for transplant rejection. This is used for prophylaxis of transplant rejection only. They both inhibit IL-2, and they're both given with corticosteroids. They both enter T cells and bind to a binding protein, which in turn inhibits calcineurin. So your tacrolimus is here, and your cyclosporin is here. So they bind to these proteins, which will, I guess, reduce your calcineurin inhibitors from doing their job. So they inhibit the calcineurin. These will cause nephrotoxicity associated with mucoid deposits in the arterioles and focal fibrosis. Cool. So your mTOR inhibitors as inhibition of IL-2 signal transduction. So your method of action here is inhibits IL-2 signal transduction and thus T cell lymphocyte proliferation by IL-2. So this is different from your inhibition of this one here, which is your inhibition of IL-2 expression. This inhibits that kind of signal transduction pathway. So this is production here, where your IL-2 is up here. I have a thing above it. Your IL-2 here prevents it from going through. So these are examples of sirolimus. So this is used in prophylaxis with transplant rejection and coronary stents, and has low oral absorption. It can cause thrombocytopenia, less nephrotoxic than calcineurin inhibitors, but it's still somewhat nephrotoxic, I guess. And there's increased risk of renal function impairment when used with cyclosporin. It is used in dual therapy with calcineurin inhibitors. So these ones back here, but they are just used in general. All right, so T cell proliferation inhibitors. So these are your cyclophosphamide, which inhibits all cell proliferations. This is one of your older ones. And it's used in lower doses than for cytotoxic uses in cancer when it is used for immunosuppression. So used in cases of renal disease, which is where it's most commonly used. You also have anti-metabolites. So these overall inhibit T cell proliferation. Now, whilst that doesn't make super heaps of sense, because these anti-metabolites are used in kind of all cell when they reproduce or replicate, such as pyrimidine and purines, T cells will need it more. And so therefore, because they kind of replicate faster and they need it more, they'll be more affected. And so therefore, they are overall selectively targeted and inhibited by that. So mycophenolate is used in prophylaxis for transplant rejection and RA. It's a pro-drug metabolism in the liver and will directly inhibit the kind of synthesis of purines. And as a result, suppress those cells. It can also affect your hematological cells and your gastrointestinal cells because they are also fairly fast or rapidly replicative. And so therefore, they will cause symptoms there too. Your leflutamide used in RA, GN, SLE, and kidney transplants will inhibit pyrimidine synthesis, and therefore it's had an effect on there. Your anti-cytokines. So these are immunosuppressant antibodies, which have two approaches. They either will antagonize the receptor, so block the cytokine receptor, or they will be a soluble receptor which binds released cytokines and not membrane-bound cytokine receptors, i.e. they just kind of bind to the ones that are already in the bloodstream or in the kind of area. Now, I will not say you need to know these specific antibodies or monoclonal antibodies. Just know they kind of exist and what they kind of are. So these are basilicimab, etanercept, anakinra, and rituximab. They are basically just targeting specific cytokines, and they will be used in different purposes. But what specifically those are is not something you guys need to know, I don't think. Okay, so this is prophylactic drugs you need to take whilst you're on these. Basically, what I want you to think in terms of like what problems could they have when they are on these medications, and therefore prevent them by doing the treatment for that. So they can have more infections because they have terrible white cell counts. So they can give them prophylaxis for prophylactic antibiotics, for instance, or they can give them prophylactic immunizations, things like that. They have more likely to have anticoagulation problems. So therefore, you need to give them drugs which target that sort of approach. They are more likely to have diabetes and diabetic risk. And so therefore, you might need to give them statins or antidiabetic drugs to control that as much as you can. They might have bone preservation. So they might require calcium as their kind of body doesn't produce it normally. They might have ulcer because they may get ulcers because the drugs reduce the kind of normal sort of gastric mucus production, causing you to have more ulcers, and so therefore you might reduce the acid content with PPIs. So therefore, it's kind of how that sort of thinking works. So this is the flip side. So these are immunostimulants, and there's not much on here. So basically, this is used when you have an impaired reaction or you don't have enough. So types are thalidomide or interferons. The thalidomide will enhance your T cell production of cytokines. The adverse effects is your multiple myeloma, thrombosis, and peripheral neuropathy. Your big one is it's contradicted in pregnancy. This is the infamous one that I think had lawsuits and all that class action things against it, but they found it was useful for enhancing T cell production. But it's not used in pregnancy because it can cause serious problems. Interferon binds to cell receptors, which inhibits viral penetration, translation, transcription, and protein processing. Effectively, it's we're giving them the cytokine we were stopping beforehand. Because we're giving them the cytokine, they're going to get flu-like symptoms because that's what they will naturally produce anyway in their body when they'll fight this infection, causing flu-like symptoms, hypertension, depression. Your other group is interleukins. This is basically just giving them IL-2, causing immune cell proliferation to release the multiple cytokines. It can cause hypertension, capillary syndrome, and cardiac failure as a kind of side effect. These are all used for hepatitis B and C, leukemia, hairy cell, Kaposi sarcoma, melanoma, and MS, but they are just your immunostimulants. And that is all. So, if you have any questions or any queries, I need to somehow stop share. I will stop recording